Dr. Box and I have been having meetings with more and more groups, and she is very good at delivering the message, and we have gotten nothing but good responses from county commissioners, school business officials, mayors. We're going to meet with the Indiana Chamber of Commerce at the annual meeting in June down at French Lick. We've met with 15 or 20 groups, and we just keep going, and we feel like this is part of the building block process for two reasons. Number one, we honestly need to work and find out where people are who are in the field and where they want to go and what they want us to do and how we can do this and really develop something that's important for the future of Indiana. I think this is really the most important subject matter agenda that we may be facing in the legislature here in the next 3 or 4 years. So we're right in on at the right time on doing all of this. But secondly, you have to be realistic in recognizing that the pandemic is part of what has precipitated all this discussion, and why should we do something, and why should we have these conversations? And at the same time, it's clear that on 2 or 3 very significant issues, there's a lot of conflict among people, among decision makers, policy makers, legislators, just anybody you want to name. And so I think the reason for our methodical approach here in building this up and getting to the right answer at the right time is that it's too important for us not to succeed at this. And so we need to lay the groundwork in a way that shows everybody that really the short-term issues of the day have nothing to do with how you're improving public health in Indiana. And I think if we can do this properly, that this will provide a basis and a platform not only for improving public health, but I think it will begin to build the networks of all the healthcare types of providers and situations so that Indiana can really be have a very good culture in terms of how we do all these things. So I appreciate your patience and diligence. I would remind you that the meetings that we're having now, some of you are antsy, you want to start working on a product right now. And I don't blame you for wanting to do that, because I want to do it, and I keep telling Dr. Fox what I want to do. So, but the reality is, if you look back at your outline, the 6 work streams that we have are really probably chapter titles of what's going to need to be in this report. And so in all fairness, we need to have ourselves fully educated and apprised of the facts on those 6 work streams. And we're going to have a session today, very important, about children and what we can do in that regard. And then next month, we'll have one on emergency preparedness. But also next month, I think we'll be ready to start digging into some discussions about how the report ought to look and what it ought to contain. And from that point forward, if we go according to schedule as we would like to, I think your patience will be rewarded with your ability to weigh in heavily and extensively over the next 2 or 3 months of building a product that we can take and get done. It is as noble as our cause is. If we do not get something put in front of the 2023 legislative session with statutory language that improves the delivery of public health in the state of Indiana and funds it up appropriately, then it won't, I won't say it be for naught, but we will just have missed the great opportunity that we need to take advantage of. So our task is to succeed in that regard. And I appreciate your patience. And so I'm going to let the other co-chairs and our citizens representative make a few comments. But Dr. Box, would you lead us off? Do you have anything to share with the commission at this point?
Sure. Good afternoon. I'm really glad that we're meeting in person. It's nice to have the COVID numbers come down as quickly as they went up in our state, like it did in every other state. I wanted to share that we are hosting tomorrow the Commission's first listening tour in Jasper, Indiana. I think that's from 11 to 1. As you know, our January sessions were rescheduled because of Omicron and the significant numbers we had at that time. Today, I think our discussion is really important, and some people might wonder, how does this really impact, public health, or how does public health impact this discussion of the integration of childhood and adolescent services? But it was very clear throughout the pandemic, and we've always known how much public health is delivered through our school systems, and how important that is to get kids started off right with their visual and hearing screenings and their scoliosis screenings and their immunizations and everything else. So I want to say to you that this year, for the first time since 2015, Indiana will be receiving, and have received already, some of our weighted data from the YRBS, the Youth Risk Behavior Survey, because 88% of the schools that we reached out to had discussions with the superintendents, and the principals actually took part in it. And it actually, 9th through 12th grade, we received enough of all of our minority populations that it is going to be weighted data in all of those areas. So I'm really excited about it. But what I want to say is that, and the other thing that people don't realize is that this will allow us, now that we've gotten weighted data, to be compared to other states. So we won't just have Indiana's data. We'll be able to say, well, Indiana, 38% of your students say that they text or emailed while driving in the past 30 days. These are looking at risky behaviors that could change this person's life for the rest of their life or end it. That 15% of students report being bullied on school property, and that 47% of students report feeling sad or hopeless for longer than 2 weeks in the past year, and that 28% of students seriously considered attempting suicide. Now, where do we compare to other states? Are we a lot worse than other states during this pandemic? Is this just a pandemic influence? We don't have past years to compare to, unfortunately, for Indiana. And that 19% of students have vaped in the past 30 days, which breaks my heart, because we're addicting the next generation to nicotine. And there are many more categories which the students answered questions about: drugs, driving under the influence, smoking, vaping, all kinds of things. But sharing that data in the next coming months, we'll put that into a form that we can compare ourselves to other states, that we'll be having graphs and other things. And now it's our obligation to get this out to our partners so we can use this data to actually implement evidence-based programming depending on what issues we really see as being the biggest issues. And we saw this in Fishers with regards to suicide and depression up there, and they hadn't had a suicide for years based on the evidence-based implementation of programming that they did. So it's really important that we address public health and how we start and interact and integrate that public health with our students, so that we really can help them build a healthy and a resilient next generation of Hoosiers. So thank you.
Thank you, Dr. Box. Dr. Box has just done a terrific job on these Zoom calls that she and I have had. I think we ended up with like 16 or 18 Zoom calls and only one live meeting. And, but you all can't imagine what a great ambassador she is in all these various different groups. So I feel very good about
Thank you.
We've gone so far. Susan, what would you like?
Well, speaking of that, I was just looking up the title of the podcast that Dr. Monroe and Dr. Box represented our commission on February 8th, and they were interviewed by a group that I'm a part of. It's called Center for Strategic International Studies, CSIS, a think tank based in Washington, D.C. There's been a group that's been around for a couple of years now, all about strengthening America's health security. We were formed before the pandemic, but we've worked really hard through the pandemic. Steve Morrison just hosted Judy and Chris, and they just did a podcast February 8th. So I was just looking up the title of it really quickly. Probably what's going on in Indiana.
Yeah, there's definitely Indiana in the title.
Right. Yeah. It's really just, public health, restructuring public health. What are the barriers to that? And what are the things that we're doing? So it was
if you'd like to hear
amazing
what our leaders had
discussion.
to say on that podcast, check it out. I'm really looking forward to the presentation about adolescent and children's health. I think there's probably not been an issue that more folks have felt passionate about than the issues around masks on kids, even more so than vaccines, I think. And so there's been a lot of parent engagement, a lot of community engagement around the issues of masks and of the issues of how our children are learning. especially since this pandemic. And I think I'd just like to commend, I understand Dr. Box today and the governor just released some new guidelines. So I'd like to kick it over to you to share with them. But I think this has been a really trying time for our children, our administrators. I'm the daughter of a teacher, sister of a teacher, mother of a teacher. It's been a really, really tough time for our educators. Tougher than ever for school boards, tougher than ever for superintendents, and but I think toughest of all for kids who have never maybe seen their classmates' faces or their teachers' faces. And so there are a lot of challenges that we've all been going through. And so what is the state going to be doing? And I yield back.
Thank you so much, Congresswoman. So we did, and I've got to say, the first thing I said to our schools and local health departments that were on a webinar with us at 10 from 10 to 11 today was, thanks for fighting the good fight. They have fought the good fight every day through this process, trying to keep kids in school and keep their kids healthy. And Indiana has been incredible, I believe, with a number of days that our kids have had in school. So Dr. Welsh, Mindy, Dr. Kane, thank you for everything that you've done. But today we did announce that the Indiana State Department of Health is no longer requiring or recommending that any contact tracing or any quarantine would need to be done in schools, and that they no longer have to report any cases to the State Department of Health, which is a huge burden, which is removed from local health departments and schools. We will continue to support the federal mask mandate for busing, for masks being worn on buses. And we will continue to support the fact that an individual who is isolated because they're positive for COVID-19, when they come back after day 5, so on day 6 through 10, that they should still be masked so that they can protect any individuals from spreading that. And it was incredibly well received. We felt very comfortable doing this with our numbers falling as drastically as they are. One of our goals, Dr. Weaver and I said from the very beginning, is to make sure that every child that needs to go to school and be there in person has the opportunity to be vaccinated before we remove some of these things, or even support the removal of some of these things. And our 5 to 11-year-olds have been able to be vaccinated now since November the 3rd, so about 12 weeks. So we're very excited. We will now go to standard type operating with other diseases. I mean, I was amazed when my team, Pam Pontonis, our health epidemiologist, is here. We have a 139-page handbook for the schools with all over 45 infectious diseases. Some diseases I had to look up because I hadn't even remembered them from medical school, and all the ways that we handle it. So I think that this will now become a part of that, and we'll have some specific recommendations that are infectious disease oriented. So thank you for bringing that up, Congresswoman.
Good news, Dr. Box. Thank you. Dr. Monroe, anything to add today?
Yeah, I would like to add a few remarks. First of all, great to see all of you. And again, what a privilege to serve with all of you. I have to say, the fact that we're going to be focusing on children and adolescents today, I was walking here from my hotel to come to the meeting, and there was a big line of, 12 or 15 young children, maybe 5 years old, that were with some adults, and they were looking at the State House, and they were all bundled up, but were waving and animated, and there's I just had a big smile on my face. There's nothing greater than healthy children, right? And then when we think about public health is so much more than preventing diseases or responding to pandemics, as you said, as everybody's been saying. So it's really about building the foundation of a healthy community. And the health of our young ones, which is just a good indicator of overall health of the community if we've got healthy little ones, right? And then when we think about the lifetime of good health, that starts in childhood. It starts at an early age, and it's why we need to maximize every health opportunity, every touch point for our children and our adolescents. So whether someone is a mental health counselor, a school nurse, a clinician, folks in those professions all have an opportunity to provide care and education that will really make a difference in children's health. A healthy child's able to learn better, which is critical to the economy of a state, the well-being of a community, and they go on to lead successful lives. So I think today's conversation particularly is really important to the work of the commission. As we look to the impact of adverse childhood events, we look at missed opportunities and ways to provide more support to some of our most vulnerable, regardless of where they live, learn, pray or play. And so I look forward to today's conversation.
Thank you, Dr. Monroe. We did hand out some minutes, so could I have a motion to approve the minutes? Is there a second? We'll take that by consent.
Mhm.
Thank you. Okay, the next agenda item, we have public input summary, and then we're going to ask Dennis Dawes from Hendricks County, a county commissioner, to share his thoughts about the issues that we're dealing with here at large. Shane, what do you have on public input? What do you got for us today?
Thanks, Mr. Chair. We had 102 comments during the last comment period. Of those, 84 were related to the role of public health and COVID vaccine and mask mandates. Both of those really can you hear me now?
Speak up. Just
Okay. Both of those in opposition to the expansion of public health authority, as well as opposition to vaccine and mask mandates. There were also 6 comments specifically related to the composition of the commission, including having former CDC officials and others from the federal government involved. A lot of these were really, the previous 84 as well as these were really form-based, and it seemed to be kind of a copy and paste feedback. And so it looks like there was kind of a concerted effort there. 5 individuals commented that they were upset that the listening tours were canceled. As Dr. Box mentioned, we have rescheduled those. That updated schedule is online, and we have provided an updated map and schedule in your packets as well. And our first one is tomorrow in Jasper, and then next Friday we're in Newcastle, Indiana. 3 individuals commented specifically on adolescent and childhood health issues. 1 interested in solutions for chronic health conditions, and 2 were opposed to sharing of health information of children with state or any other institutions. 3 individuals commented specifically on COVID vaccines and mask mandates in support of those, as well as advocating for consistency across school boards and not having local school boards make those decisions. And then 1 respondent was in favor of increasing public health funding, especially in regards to allocation of pay and resources for public health professionals.
So we're starting to draw a little attention. Some of it's negative. I know that Congresswoman Brooks can share with me my experience in the legislature that you generally hear from your critics before you hear from anybody else. But I do think it's good to keep this going and to keep monitoring that. And maybe the executive committee group up here, if we see some trends or things we think we need to reach out to somebody, there might be a reason why we would want to do that at some point. So I do think it has some value. Appreciate you taking care of that, collecting that information for us. Any comments about Shane's report?
Just welcome more input from the public.
Right. Dennis Dawes, County Commissioner from Hendricks County. We are going to give you the floor for a little bit, Dennis.
Thank you. When Shane called me, asking how much time I had, and I told him my comments might take an hour, he hung up on me. So I think I got the message. I'm speaking today for myself. I have this written down. I can give to you so that might help when you make notes. I'm speaking today for myself. I really haven't cleared any of my comments with the Indiana Association of County Commissioners or the Association of Indiana Counties. However, I believe most of my comments will be supported by both of those groups. And at some point in time, have the opportunity to share this with them as well. Some of what I say, probably a few thoughts or things you've heard me say before. And as my wife tells me, it helps if she repeats that. The major role of government as I see it, is to provide for the public safety. And that takes into account a lot of broad areas of services. But public health is a public safety function, just as fire protection, emergency management, law enforcement are public safety functions. And I want to use Hendricks County as an example, so I'm going to outline some things, some of my thoughts around Hendricks County. And that will lead me to some concluding comments. Hendricks County has a population of approximately 180,000 people. The median age of Hendricks County residents is 37 years old.
Wow.
There are two main hospital systems in Hendricks County: IU Health West, located in Avon, and Hendricks Regional Health, which is Hendricks County Hospital in Danville, where I worked for 4 years. The overall 2022 budget for the government of Hendricks County is just under $100 million. The Hendricks County Health Department has 22 employees, 1 physician health officer, 13 employees in environmental health, 6 employees in public health nursing, and 2 employees in healthy families. In addition, there are 2 employees working for the county emergency management. The budget, remember I told you the county's budget is just under $100 million. It's pushing right at that. The budget for 2022 for the Hendricks County Health Department and for Hendricks County Emergency Management together is just under $2 million. So that's roughly 2% of the total budget for Hendricks County spent on public health and emergency management, which go hand in hand. In addition to that, Hendricks County is not paying the public health physician. That physician is paid by Hendricks Regional Health, the county hospital. And then all of the public school systems in the county have health nurses at the school systems. Those individuals are employed by the county hospital as well. So they're not paid by Hendricks County either. And I think that is significant. Now, I'm aware that there are some other counties in the state that have a similar arrangement where the local hospital, and it may not be the county hospital, pays for the nurses to be in the school system. They may not pay for the physician to be the public health physician for the county. So other than Marion County, which is contiguous to Hendricks County, Hendricks County has contiguous to it Boone County with a population of 68,000 people, Montgomery County with a population of 38,000 people, Putnam County with a population of 38,000, and Morgan County with a population of 70,000. If you add those 5 counties together, including Hendricks, the population is roughly 395,000 people. That is not quite half the size of Marion. But if there was one health department, an emergency management department for those 5 counties, Hendricks, Boone, Montgomery, Putnam, and Morgan, there could be a considerable savings in operating dollars, and I would imagine an increase in the provision of public health services and emergency management to those 5 counties. So with that said, using Hendricks County and kind of the contiguous counties to it, I fully support the concept that this commission has stated. Not that everybody say you're in agreement, but I fully support the commission doing some sort of regionalization of public health across the state And to me, that will improve public health services provided. Working together with the healthcare providers, meaning the hospitals or hospital systems. And to me, that goes hand in hand. We have to work together. Some additional thoughts. Perhaps there would be a community-wide healthcare assessment that would be conducted by the regional public health and healthcare providers that would develop specific public health and healthcare goals that would include achievable outcomes. We need to look at best practices and establish public health indices with a dashboard that all agencies can review and compare themselves to. That may be available in different forms right now. I really don't know. How to develop a statewide regional public health system will be difficult, I'm sure, but I will personally can do that. I don't think it's impossible. And then I'll end on some specific data points from Hendricks County related to COVID. The Public Health Department and the two hospital systems in Hendricks County have worked hand in hand over the last 2 years to tackle the pandemic. All Hendricks County schools are now giving parents and students the option to wear a mask or not to wear a mask. COVID cases per day in Hendricks County have dropped from 203 cases per day a few weeks ago to 49 cases per day currently. The COVID positivity rate has dropped from 35.4% to 18.7%, which is still higher than I think the state average, but it has dropped considerably. The COVID vaccination rate for Hendricks County is 67.5%, which is the third highest in the state. Hamilton is 1 and Boone County is 2. Hendricks County deaths due to COVID, or at least they're counted that way, during the past month were 37, with the median age of 81 years old, and almost all of them were unvaccinated. Hendricks County believes in being vaccinated. We have worked hard to educate the public in that regard, but we do not mandate the COVID vaccine at all. I am sure the Indiana Association of County Commissioners will work with the Governor's Public Health Commission and promote and support the report that this commission will put together that will go to the governor and eventually to the legislature. I'm positive that it's really an honor to serve with each of you on this Public Health Commission. And we probably need to add some comments in our report on manpower issues facing public health and healthcare in general. And I'm glad to see some current bills in this legislature this year that address some of those issues already. And thanks to Brian and the Indiana Hospital Association for your work in that regard as well. So my best as we move forward. Thank you.
Thank you.
Thank you, Dennis, for that thoughtful report there. I'm sure that some of those ideas and thoughts you have there will, in the coming months, will be topics that we'll be discussing. We have reached out and had a meeting with the county commissioners, a group, and one of the things that we were talking about earlier this morning as we prepared for this meeting was whether we might need to circle back with the county commissioners and maybe the county councils to have another forum with them to kind of make sure the direction that we're going is receiving some support from local government. I wonder if you and Bob wouldn't mind following up with those groups and the mayors. We're not just asking for more meetings and more workloads, but I do think those are going to be key groups when it comes to getting the legislators motivated to be helpful to us. I think if they have a feel that this is going to be important to them, that will help tremendously. So
I agree with your comments, and as I think we've all heard through some of the discussion, that the commissioners as a policy body can make comments or even pass an ordinance or whatever from a policy standpoint, but unless it's funded by the county council, it's going anywhere.
Mhm.
And so that is a very important group that is part of this. And so I certainly will talk with the Association of County Commissioners, and I can reach out also to Association of Counties. and,
Great.
Make sure they're aware that we would like to have some kind of discussion with them again.
That'd
I'm
be
sure
great.
they would want to do that.
That'd be great. If you guys could do that a little bit and then maybe just get back with Shane or us, then we need to keep measuring where we are with these folks, I think. Good report. Thank you. Local health officer meeting report, Dr. Kane and Dr. Welsh, you were brave enough to take that on for us. How did it go?
I thought it was fantastic, but I'm gonna let Dave start off.
First of all, I want to thank Kim Irwin and the State Department of Health staff for helping get the health officers together, as many as we could. And just for the record, if you need me to work on something with Dr. King, anytime, anywhere, the answer is yes. She is fantastic work with.
Awesome.
We're having too much fun.
So first of all, the health officers were very appreciative of being asked. Secondly, they want another meeting. And I spoke with Honorable Lieutenant Henley about maybe, he was saying maybe June would be a good time, given our timeline for our committee. Commissioner Dawes, it's like you were in our meeting. Many of your comments fit right in place with our county health officers across the state. I'll start with the regional effects. We have a lot of small local health departments, small county health departments, and if they get stressed, they can't meet the basic needs, let alone what the stress needs are. So regionalization is something they are in favor of. They certainly stress that some activities need to stay local, but if those activities are strained, that there would be a mechanism to bring in resources either from the district or regional district or the state, much like our strike teams that we're doing now with COVID-19. If we can get resources in a regional way, we've spoken before about like an epidemiologist to help them with that. That would be a good example. Along with the regionalization, also education, whether it comes from a regional, the state, or Dr. Halverson's public health school. His name came up quite a bit in the discussion. People were very appreciative of the resource of the Fairbanks School of Public Health to the state. And I think they would like to see more of that. A number of health officers want more education when they start and then ongoing, so that they can stay current and do their job as best as possible. It was interesting, Dr. Fox mentioned about the K through 12. There was an interest for more interaction between the health departments and our schools, particularly the school nursing, so that we can work in tandem together and get more accomplished, much to Commissioner Dawes' comments of working together. There was also a lot of talk about workforce, that we have a short bench and there's difficulty in getting folks lined up. And along those lines, there was interest in knowing what the pay scale was across the state. So people knew what the proper amounts in order to recruit and retain folks are. And also it goes to the county council's budgeting. So if we go to the county council, we have to replace this school nurse or this health department nurse. This was the old pay, but we're having trouble recruiting for what we need across the state. This is the range. Would you see your way through to helping us with an increase in that location? And that data would help. Which takes us to the next step. We've talked before about data. Overwhelmingly, the health officers are interested in more access to data. Not only the access, but help analyzing it and how to respond to it. Gets back to the education. So they'd like to have more data. They'd like to know more what's going on, not only in their county, but in the region. It gets back to the regional approach.
Mhm.
So that if there's a problem, so I'm in Ripley and Franklin County. If there's a problem in Decatur County, first, we're gonna talk, I'm gonna know about it, but otherwise, it would be nice to know if there's an uptick there of, say, hepatitis A or syphilis, like one of our other counties. So if we had a regional information that we need, then prepare the counties that haven't been hit yet, but maybe it's the ripple effect, it will affect them. Funding challenges was another area that gained a lot of attention. And gets back to learning how to communicate better with our commissioners and our councilmen, how to make that message understandable and receptive. And there's an act to that. I think we all realize that. Folks at the head table do a really good job of communicating. And some other folks work really hard, but they're not as adept as our leaders are. So any help along those lines would be helpful. And that gets to emergency preparedness. So emergency preparedness, as a general surgeon, that's big on my list. I understand it. As a surgeon, I live it because it's part of trauma and triage. But it may be difficult for some to explain why that's important to the local businessmen, to the local commissioners and councilmen, to the lay folks. And if we can get help with how to communicate some of those important tenets to different audiences, so that we get more reception and more help for this very important area. One of the other things that came up with regionalization, you spoke about working with hospitals. The health departments that work with their local hospitals are the most successful. And I know the feelings of our Indiana Hospital Association about helping the public and helping with public health. And I'm really happy to see Mr. Tabor across the table from me. But I've known him for a number of years. I know his points of view. And if we can just continue to encourage health departments to work with their local hospitals, and again, from a regional standpoint, I think we will get to a better outcome. I spoke this earlier, Dr. Keenan and I spoke, and she had an interesting comment that she learned from it on the funding challenges.
So one of the issues for a lot of our local health departments, and I think you made it very clear about what that budget was for $2 million for Hendricks County, is that they don't always have an opportunity to grow. So let's say they're able to identify a grant to provide some additional funding for activities, or they're lucky enough for a foundation or some organization to give them money. What happens frequently with them is that whatever new dollars they bring in, then the city budget removes their general funds away from them. So it's a negative gain and they're left with the same budget. And they try to get these new grants or new activities or new funding so they can help expand their workforce in order to do more public health activity. But it's translated by the sometimes the city leadership. We're not going to have your budget increase. So if you don't need this money because you found some other dollars, we're taking your general funds away from you and we'll give it to someplace else. Part of that, they feel that public health is a lower priority in the city. So when it comes to like maybe law enforcement, they get a higher priority. Or the fire department, they get a higher priority. Or your ambulances, emergency services, they get a higher priority. So they feel that they're sort of lower on that priority list, why they're not allowed to keep their budget. Then the other thing that's really critical, and this is with the workforce capacity, is like you said, someone goes on vacation or someone gets sick, they don't have that fallback for someone to help do that additional work. They have no leverage related to that. And so they can get behind real quickly for their public performances. And this is where they don't have a good grasp of understanding of what a public health nurse salary should be. They don't distinguish that as a health person, a specialized service, for example, a public health nurse should make more money than just say, and I'm not knocking any other position, but a non-health position they should be making the same amount of money and the same level of salary. This is maybe your environmentalist, I guess, a specialist, maybe how we equate that. So what does that mean? It is very difficult for them to recruit anybody because their city leadership or commissioner leadership never allows that salary to get higher. And a lot of these health departments, their salary levels haven't been reviewed or looked at or evaluated over 10 years. And I don't want to go further. Some of them are almost 20 years. Would you believe it? Inflation has taken place in this country. Inflation, okay? So it's so hard to, if you recruit them, how do you sustain and maintain them without making those adjustments or understanding those adjustments? So it may not necessarily help you looking at all the public nurse salaries in the surrounding counties. They may be in the same boat. You need to look at what is a hospital nurse making and why is there a big gap related to that, okay? So, you know, I'm part of a corporation that has hospital nurses, and I have public health nurses, and I look at the different salary ranges, and well, you know, they get this critical care in these hospitals. They work very hard. I said, yes, but guess what? My nurses will go out in the community. They've got our employees will knock on a door. I don't know what's going to be behind that door. And so they're at risk too, maybe greater risk from a safety standpoint if I'm doing community outreach and work out there. But I do know something is not right when it's taken us 10 or 15 years to review the salaries and there have not been any adjustments. So they're looking for leadership in terms of what should that be and how do we articulate the importance related to that as a result of this COVID epidemic. And I do think just some additional points. They would love to be able to access data. They love for someone to analyze the data, but you still have to have a person inside the health department to help coordinate that. Okay, that's additional work in that health department. I want to know what's going on when trends are happening, but who is also helping me with that? So those regional assistance sources, they can help do that. That's fine because a lot of public health, we get sometimes additional mandates, but there's no funding that comes behind those additional mandates. So sometimes we're a little leery about additional mandates, but if we could provide some regional sources, that would be phenomenal, especially the training. Are there any certifications I can get in a certain area? If I train to give me the certification and that allows me to get some services, but I do have to say this and caution us on the training. Sometimes when people get the additional training and the certification, next thing I know, I'm getting my email to say, now, why am I not getting my raise now? Since I've got this additional certification or I've got this additional degree. So that's something got to figure that out.
Good point.
But one last thing, and I think this is so critical. They were so complimentary of the Indiana State Department of Health and what they thought was the response to them from a technical assistance to the local health department. And that was almost unanimous related to that. And I thought that they felt that every time they made a call, it was timely. People made a response to them, did their yes. So they and that was from almost all of the health departments. One issue though sometimes is, you know, a lot of public health, we do a lot of reimbursement rates. So are there ever any opportunities for this, for the commission to look at that some health departments might need some upfront money to start their initiatives? Because, you know, if I have to post a position, I've got to wait, you know, a month or two before I hire that person, and the contract doesn't start paying me until that person is hired. Are there any way we can be more agile or flexibility that sometimes for certain initiatives give a small upfront dollars to get them started. And then once they got that upfront, maybe it's just a small amount of money, but then they can go the reimbursement route for some of the smaller health departments. It would be a benefit.
So we're very big on the regionalization, interacting with hospitals and schools in particular. We're very big on trying to improve the workforce issues. Very strong interest in the data collection, analysis, and then implementing plans. But all that comes back to education and training, which was a key ask. And of course, how to help with communication across the board, interacting with these different stakeholders and our local officials, and as well as dealing with some of the funding challenges. So very productive meeting. Also heard from some who could not make the meeting at the time given. So additional information from the folks that I've included, we've included in the report. But overall, they were very appreciative of being asked. They would like to have further conversation. And I thought that was very positive. And again, I can't say stronger than Dr. King, how appreciative all of them were of our Indiana State Department of Health and helping them to respond to this crisis that we've been dealing with for 2 years.
How many people were in on the meeting and about how many counties were represented? Do you have any idea?
Who's it about?
But I thought it was over like 45 or so,
I think
and then
that's
I
about-
got responses probably from another dozen.
So it's a pretty good cross section.
Yeah.
Out
Yes,
of
it
94.
was- And it was across the state. We had large counties, small counties.
Okay,
We had some folks who represented 2 counties that helped with multiple counties. But that's why I was really appreciative of Tim Irwin's help with mustering the troops. Her roll call was very helpful.
Kim, anything?
I have a question that's separate but related.
Okay.
Nothing to add.
Well, thank you very much for conducting the meeting and doing the report. And I'm so glad I don't have to negotiate budgets with Dr. Kane.
Well, again, if you need something done and you get Dr. King involved, just sign me up. I'll be happy to be
We may have a role for her when it comes time to talk to the legislators.
Oh, yeah. Oh, yeah.
No, he was just a great GC. He really started to set the tone so well for the local health officers. And like I said, they were so honored and delighted to be able to provide their input, have an opportunity to talk about what some of their issues were, what they thought could really help for the future of public health here in Indiana. And they commended the fact that the governor had the commission on public health. When you look across the country, no one else is doing this right now. So they did want to emphasize and thank Governor Holcomb and the chairs and Dr. Watts for taking this very valuable time to really look and delve into this area. So very grateful.
And related to this report, there are
What's the email
colleagues
she was
across
talking
the nation that have heard about this commission. They also heard about our
Same
evening discussion with our county health officers. And I had colleagues reaching out to me from other states, commending Indiana on this commission, and the fact that we sat down, that King and I sat down with the health officers to get their input, because apparently that's not being done very often. So this commission needs to know that the eyes of the nation are watching and they're appreciative of the efforts.
Great.
Thank you guys so much for doing that.
I hate to tell you this.
Senator Kinley.
Kinley.
They love the fact that they have a state policy maker with experience being part of this process. They thought that was critical for this process, someone who understands the ins and outs of state legislation. And so they're putting a lot
Good. I'm not going to disappoint them.
on
Nope.
you. Helping to educate your colleagues. And then,
That is
of
huge.
course, they love Dr. Dr. Monroe, a very proper person, well known. Oh, they knew Dr. Monroe when she was in state health. So we heard about that, and they went in on and some other items, but they also love the word that you had foundation behind your name. Dr. Monroe.
Good.
So from a funding standpoint.
They all have your number now.
I'll start mobilizing more.
Yeah, no, I just want to say we are really proud of the growing relationship between Insecurity and IPHA and working with Dean Homerson and Shandy Dirk and team and all that. So that was a good example of a partnership for sure. My question is just in going back to Commissioner Dawes' comment, do we have a compilation of the types and kind of amount of public health services that are being provided through hospital systems or clinical systems? I can't remember if we've seen that data or if it's in the report, the system report.
It's not the report.
There are not that many counties that are combined with the hospital running public health services.
Not formally, I'm thinking less formally. And can I just make one more comment? And then I think sort of standing pre-pandemic and sort of traditional public health, and then with the pandemic, as we think about emergency preparedness, where did hospitals fill gaps there?
So as Commissioner Dawes was speaking, I started to type up an email to our team for us to put together a survey for that.
Good.
It's something that I could probably look at the map and give you some pretty good examples going around the state. But adding that up, I think is really important. So we're going to do our best to pull that together quickly. It is significant, and that what Commissioner Dawes with Hendricks Regional provides is wonderful example. I do know that it is there are similar relationships, not just with county hospitals, but with others. But I do get a sense of the range. So I hope that some of that will come out through the hearings as well. But we need to quantify that. But if I could just add one other thing too, is that Dr. Kane mentioned this. One of the things that's going to be very important for us is quantifying that return on investment. Because we've heard over and over that whether it's ability to bill Medicaid or just the ability to have enough trained staff to apply for and hold on to grants. I can only imagine what happens in the middle of the grant process and you have turnover. So getting the dollars, keeping it, I have to think that is hugely significant. And so when we look at where we rank, I think that's partly because our folks on the ground don't have the resources to apply and those dollars. So I don't know how to do that. That's going to be a little tricky, but I think quantifying that return on investment. So when we say to the legislature, we need X, we're going to be able to pull in X times 7, 8, 10, maybe a bigger number. It's going to be hard work, but I think that will be.
I think that'll help sell our case too.
In that pipeline, they really wanted a lot of concentration in the schools for the pipeline. So whether it's environmental health, whether it's public health nursing, any area, we really need to strengthen that so that we will have folks to hire from a workforce capacity in the future. We need to really be looking at that very closely.
Good transition into
Great.
our.
Thank you. Good discussion. Now, Dennis.
Another quick comment. You don't have to call me Commissioner Dawes. Denny is fine. Dennis the Menace.
Dennis the Menace.
You know, Indiana is a state of 92 counties, and there used to be almost 92 county-owned hospitals in the state of Indiana. There's only, what, Brian, 20 to 25 now that remain of county-owned hospitals. The commissioners of the county typically appoint the board of that county hospital. So there's a tie-in there. So there's a lot of counties in the state now that do not have a county hospital that I won't say that the commissioners can go to and say, you need to do this or whatever. It's a private hospital, it might be for-profit, it might be not-for-profit, but it's not owned by the county. And that creates, I think, another challenge of how to get that working relationship together. And then another positive reason for a for a hospital or healthcare system to work with the school systems is you have access to all of those children in that school system and their families that you can send information home to
Mhm.
about your health system, that the family then will see that name. It's almost a marketing tool.
Yep.
And to me, that makes good sense for the local hospital, be it county owned or not, to want to work with the schools because it gives them an opportunity to have access to all of those people and their healthcare system. And, you know, I know that sounds a little crass maybe, but it makes sense.
Absolutely.
Well, I think that's a good segue into our next presentation.
Yes.
We have with us, is it Fennell, is that
Mhm.
the correct
Fennell.
pronunciation?
Dr. Maria Fennell.
Okay, Dr. Fennell is here to talk to us about adolescent and childhood health and make a presentation. She's the Chief Medical Officer at FSSA, in addition to pulling a weekly shift in the clinic.
Mhm.
She is a board certified pediatrician. So I'm going to let you enlarge your introduction if you'd like a little bit, Dr. Fennell, but thank you for being with us and we appreciate the chance to hear from your perspective what we need to deal with here. Thank you very much.
Thank you. Thank you so much for the opportunity to present. Can you hear me okay?
No,
Probably a little louder, Maria.
Speak a little louder?
Yeah, talk as loud as you can. It's pretty hard in here.
Okay. I'm going to move to the next slide. I just want to point out quickly that this presentation was put together by myself, but also with the help of Amy Lewis-Gilbert, who is our Chief Science Officer in the Family and Social Services Administration. She has been a huge help here. Here's our note of thanks. Just to begin, I will point out that this is a huge topic, broad topic. In no way are we able to do a fully comprehensive review of everything in child and adolescent health. What we have done, though, is that we have done a review of the literature. It's not a systematic review, but we have done a review of literature, and we have really tried to talk to people who are subject matter experts in Indiana on these topics. We have reached out, we have done structured interviews with open-ended questions, really trying to get them a chance to tell us what's going on and their opinion about things. So as you will see, we have sort of representation from clinical people, academia, the school system, Department of Education, and so on and so forth. And I want to thank all of them. They were fantastic, really gave us lots of information. The way we'll approach this presentation is that we're going to talk about the key themes that came out after talking to our stakeholders and looking at the literature. You'll see here, we're going to talk about schools, we're going to talk about vaccines, we're going to talk about STI surveillance and prevention, our problem around obesity, nutrition, and physical activity, substance use prevention, and injury and violence preventions. Huge topics. Most of the time we'll spend on supporting the schools in the delivery of public health services. We'll do that for two reasons. One, I think the pandemic really showed us what our current system can and cannot do, the way it currently looks. And two, this was something frequently brought up by all our stakeholders. They really wanted to talk about this. So we'll touch on the other subjects as well, but that will be the bulk of the presentation will be about schools. Just to sort of set the stage here a little bit, this is the current Indiana outcomes from the Annie E. Casey Foundation's Kids Count report. This is the 2022 report. As you'll see, Indiana ranks as 18 when it comes to economic well-being and 17 when it comes to education. But when it comes to health, we rank as 36 for child health. And I think I want to point out that the way that ranking is sort of the things that have been looked at is low birth weight babies, for example, children without health insurance, child and teen deaths per 100,000, and children and teens who are overweight or obese. So it's not everything, but it gives us a good measure, and we have work to do. This slide shows you sort of access points for health services for children and adolescents in Indiana. Obviously, lots of different access points, but I do think it's important to see that we have close to 2,000 public schools, under 413 local education agencies as access points for health for children in Indiana. And we'll talk more about that as in the next 2 slides. So we're going to start with talking about supporting public health in schools. There is a close relationship between health and education. Healthy students, we know, are better learners. Health risk behaviors are linked to poor grades, low test scores, and low educational outcomes. Schools plays a crucial role in promoting the health of children and adolescents and really assisting students in developing those habits and healthy behaviors that we want for them to bring into adulthood. Research has demonstrated the potential of the school health program to really have an impact, both on health, but also on academic performance. The Indiana Administrative Code requires school corporations to provide health services. You will find the presentation has also an appendix with all the details about what our Indiana Administrative Code includes, but it certainly addresses prevention, assessment, intervention, and referral. For example, schools should act as a resource to students, families, staff, and the community regarding health services, health education, and healthy environments. It should maintain a continuous health program for all students through implementing and monitoring health services. So we have quite a lot sort of that the schools are asked to do for our students. I'm going to tell you a little bit here about the 2 main mechanisms that exist for delivering health services in the schools. There are the school nurses, and then there's the school-based health centers. We in Indiana are primarily, we have primarily school nurses as a system, but it's worth to understand that there is 2 different systems and how they sometimes are funded in different ways. So to the left, the blue column there, that addresses school nurses, and to the right are the school-based health centers. So how are they different? Well, school nurses, they are the traditional school nurse that sort of exist in the school and taken responsibility to address barriers to student health. A school-based health center is a little bit more like a clinic setup. It's often located very near to the school, not necessarily in the school. They often serve the school population, but at times they can also serve the surrounding community. Funding looks different. Funding for school nurses is primarily through education dollars, versus the school-based health centers are primarily funded through insurance reimbursement, foundations, healthcare systems sometimes, as we have talked about a little bit today, and community health center funding. Both serve incredibly important roles. As we all know, school nurses can be a link to health services, including behavioral health services. They certainly handle lots of medical emergencies in schools. School-based health centers can do the same, but sometimes they also have additional services available, I should say. Oral health services, for example, they sometimes are able to do labs and things like that, much more like a clinic setup. Location, no surprise, school nurses are in the school. It should be good to know, like in Indiana, there may not be a school nurse in every school. There may well be a school nurse that is shared across a district, for example. School-based health centers can actually be that traditional brick and mortar, but it could also these days be mobile centers, and it can be telehealth, because that's what we have seen coming during the pandemic. As far as parents' involvement for school nurses, if they are going to refer somebody out of the system or share information with a healthcare provider, they need to have consent to do that. A school-based health center needs parental consent for all treatment. The other thing that's I think is good to sort of, for us all to know, is that there are actually technology for school nurses to document in a more of the way medical information is normally done, but that is an expense for the school system, and it's not typically used in Indiana. They often document in the traditional sort of education documentation system, which is not necessarily set up for medical information, versus school-based health clinics typically have more of an electronic medical record system. Okay, I'm going to talk a little bit here about school nurses. So put those school-based health centers aside a little bit, and let's talk about school nurses. We know that the American Academy of Pediatrics and the National Association of School Nurses actually recommend a nurse in every school. We know that school nurses have shown great outcomes. There are actually studies showing that there are cost savings from a societal standpoint. Parents don't miss time to go to work. Teacher time is saved, and certainly there are children that they're addressed in the school. They don't need to go to that ER or do those types of expenses. We know that students stay in school at a greater extent if we have good or if we have school nurses present. And we also know that it's correlated to vaccination rates. Our vaccination rates are higher when we have school nurses in place. In Indiana, we have the administrative code addresses sort of requirements and recommendations around school nurses. There's no mechanism to enforce that what's there is happening. School corporations are required to employ at least one bachelor level nurse, and one nurse for every 750 students is what we're currently recommending. So we don't have a system for figure. We don't know exactly where our school nurses are and how many students they serve. What we do know is that we have licensing data. So this is from the licensing bureau that they sort of reported that 2.1% of all licensed healthcare professionals in Indiana serve a school in some capacity. So when you look at those numbers, the sort of, at least my reaction was, oh, that's pretty high. But what we don't know is, we don't know if they're part-time, full-time, are they even currently serving? So. Nationally, I would say that we learned through our work that most school nurses are funded through local education dollars. Some reports cite that as high as 76.7%. So really, really reliable on education dollars. And as you know, schools have very competing priorities for those educational dollars. And there's also additional funding sources in order of prevalence. Those are state, federal, health department, hospital system, and foundation dollars. But in Indiana, our school nurses are primarily funded through local education dollars. Some other states have taken different approaches. In North Carolina, parts of the funding is allocated instead to local health departments to distribute to schools, meeting certain state established criteria, to sort of ensure that there's dollars going to health services in schools. In South Carolina, they have funds appropriate through the Department of Education. So instead of the local school district, to the Department of Education, who then, and then they allocate it to the school districts for this purpose. Some states have taken different approaches to staffing requirements, sort of requiring a full-time nurse in every school, versus in our case, as I said, it's a recommendation. Saying that though, those states that have done that, they both also report shortages, and they don't have a mechanism for enforcement either. What we heard loud and clear from our stakeholders was that staffing and retaining school nurses is a problem. And it seems like when we look at the literature across the nation that we're not alone in that. So here's the current Indiana funding for school nurses. School nurses are funded primarily by school district budgets, as mentioned. There's also Medicaid reimbursement is available for some of the school-based services. And we're going to talk a little bit more about that, what's happening in the Medicaid space. Some schools, as you have discussed, as well as partnering with health system. And what was brought up to us was that when schools do that, partner with health systems, there's a couple of things that happen. One, sometimes there's additional services that sort of just can come from that partnership with the health system. And there could be continued education for the nurses in the school. They sort of become less isolated with that partnership. It was, however, also pointed out to us that having that opportunity may not be an opportunity for all schools in Indiana at this point, that there's really differences depending where you're located. I also think it's good to point out the COVID-19 grants that has been available to local health departments that we've talked a little bit about here, and that we actually, the latest data as of last week show that 77 of 94 local health departments were participating in that. There are two Medicaid reimbursement methodologies available to schools. One is the traditional sort of claiming Medicaid claims. The other one is to get administrative claiming for some of the administration that the schools have to do around public health services. I'm gonna go to the next slide here and really show you how that looks over the last 10 years or so. So blue are the claims reimbursement. Think of that as traditional sort of a service is provided and the school acting a little bit as a healthcare provider and getting paid for what they have done. Versus the administrative claims are more about the administration that goes into around health services. As you can see, both have increased quite a lot over the last 10 years or so. And what was what this require of the schools is, of course, that they actually have to act like a healthcare provider. So our stakeholders talked at length about that. That's why it's wonderful with Medicaid dollars, and we can fund our Medicaid students this way in many ways and sort of get additional funding. It is an administrative burden, and it is creating a bit of a disparity between the schools that are able to do that, maybe larger school corporations, and the smaller ones that struggle to sort of have the administrative people able to learn this and maintain the knowledge, keep up with what Medicaid is requirement. I'm from Family and Social Services Administration, so Medicaid is sort of near and dear to my heart, but it's complex. And to sort of, that is difference, which school system can and cannot bill Medicaid effectively. Then we're going to shift gear a little bit and talk about those school-based health centers so different from school nurses, there's also school-based health centers. Some states have chosen to use state dollars to fund school-based health centers. We have not done that in Indiana. Research, however, just like with school nurses, have found that school-based health centers are very effective in improving educational and health-related outcomes. There's increased effectiveness. The more availability they have, the longer the doors are open, the better it is. There is similar to when we talked about school nurses, there's educational benefits, increased grade point average by having this service available. And there is increased health outcomes. And again, around immunizations, having that provider or school-based health centers there means that we have better immunization rates. So we also have see a decrease in ED visits and hospital utilization and those things. So similar in many ways. As I said, in Indiana, the school-based health centers are not funded through the state. There are other mechanisms. So HRSA grant funding, for example, some of our Medicaid managed care entities have partnered and set up school-based health centers through the telehealth mechanism that I've talked about. And then I do think that's important to sort of point out that this is a little bit old data, almost 5 years old now, but we had 48 total school-based health centers back in 2016, 2017. We have more added now, and during the pandemic, many have come in the shape of telehealth clinics. So telehealth services, but not necessarily always brick and mortar. So you cannot talk about health services in school without talking also about behavioral health in schools. Stakeholders really stressed, they really talked about the importance of behavioral health services in school and noted how that is different depending where you are in our state, what you have access to and not. Our statutory requirements are pretty clear. Schools must adopt policies to increase child suicide awareness and prevention. Schools must provide annual instruction on bullying. School corporations and charter school are they must enter an agreement with either a community mental health center or a mental health provider to provide behavioral health services. What we do know, though, from regular requirement is that the ratio currently of one school counselor, psychologist, or social worker, so any one of the type of people providing these services, are 1 to every 700 students. So that's a high number, I think. We can all conclude that would be hard. Just as of, I believe this week, maybe yesterday even, there's a Hopeful Futures campaign that came out. You may have heard about it on the news. Multiple organizations have sort of looked at different states and compared. And in that report, at least the way it's reported, is that our current ratio is around 400, almost 500, 497, I believe, students to each counselor. It is how it looks in our schools today. So consideration for this commission to support public health in schools that we heard was to think about mechanism to maybe untether or health and wellness in schools from the regular education budget to address that competing priorities schools frankly have for education. Think about policies aimed at decreasing current school nurse to student ratios. Ensure that those school nurses that we do have are bachelor prepared, as our statutes say. Understand some of the challenges to school nurse retention. The things we heard had to do with pay, partially. It also had to do with some of the incentives that are not quite there. You are licensed as a nurse, and then you can get an additional license through the Department of Education for school nursing, but there's really no incentive when it comes to compensation or some things like that to do that. Increase just the awareness of the link between health and school outcomes, period. And as Dr. Box talked about today, increase our participation in the youth risk behavioral surveillance system. I'm thrilled to hear that we're going to have those 2022 results so we can sort of act on them. We haven't had them for a while in the past, and I think we would all agree that we need to keep getting them. So that was brought up by our stakeholders. And then to support behavioral health access in school, to get that, what can we do to sort of get that ratio down for how many students we behavioral health counselors serve. So lots of things to consider. I'm going to now switch gear and talk about the other also really big topics when it comes to child health. So when it comes to vaccines in Indiana, good to know that state law and regulations have established a series of mandatory immunization, and the Department of Health has some flexibility there to modify the requirements. In Indiana, outside of our public health emergency that we now have been in, pharmacies are not authorized to administer vaccines to children under age 11 without a physician order. Other sort of good thing for all to be aware of is that Medicaid children, and we have a lot of children on Medicaid, they must receive their childhood vaccines through the Vaccine for Children program. And most of our pharmacies are not, at this point at least, are not enrolled as a Vaccine for Children provider. So that means that limits to some degree the access points for children on Medicaid for vaccines. Our percentage of vaccines is sort of shown in that table to the right. And I would say that we vary in Indiana, depending on sort of which vaccine, how well we score compared to the rest of the nation. That we are, depending on which vaccine I said, but the one we scored very low on is the HPV vaccine, which is vaccine given to young adolescents to prevent cancer in adulthood. And we score as ranking as 36 in the nation for that vaccine. Something that was pointed out, and I think it's worth to sort of make a note because it has also been tremendously helpful during the pandemic, is that we have the Children and Hoosier Immunization Registry Program, the CHIRP, and the data we can get from that was certainly noted as a strength. And something stakeholders really want to be able to keep and continue to have access to. So when it comes to vaccines, things for this commission to consider, what are the opportunities to increase vaccine knowledge and motivation in our state? Can we use schools where children are as a place for catch-up programs for some of the vaccines? We know we're behind after the pandemic for all the very obvious reasons. I would say that our stakeholders pointed out that there's a balance there, whether if we provide vaccines in schools, are children going to come in for those other services to their doctor to get their well child's visits? And then facilitate and support our private practitioners so that they actually administer all recommended vaccines. At this point, it has been limited how many private practitioners have been able to administer the COVID vaccine for children. It has increased, but it has to do with some of how the vaccine is coming, how many doses and so forth, but that is a limitation. I would say that that has also in the past been true for influenza vaccine, for example. That hasn't necessarily always been easy to get through your pediatrician. Many sort of have needed to go to other places to get those. Okay, we're moving forward to another big topic: obesity, nutrition, food insecurity, and physical activity. Our statutory requirements in Indiana includes health education in schools. It includes daily physical activity for young children, for our elementary students. And the school meals must meet the Department of Agriculture's nutritional requirements. With that in mind, we still have almost 17.5% of Hoosier children report that they are food insecure, meaning that they don't have access to either the quantity or the quality they should have access to. We also have quite a few areas of food desert, meaning even if they're urban areas, the food you can get to where you live is not fresh food, fruits, vegetables, things like that. It's just not available. There are, and we rank as number 38 in the nation when it comes to children's obesity. So there are currently quite a lot of initiatives going on, trying to sort of address these things, but they're not necessarily comprehensive across the state. And the screening for food insecurity that the Medicaid program is working on is for the online application. So that is happening, but there's lots to do in this area, and our outcomes are not right. Considerations for the commission would be to have policies and initiatives to support safe outdoor spaces for children to play, incorporate evidence-based school curriculums to teach students how to prepare and eat healthy foods, improve the availability of fruits and vegetables in schools, encourage training and policies to ensure nutritional food and physical activity also in daycares and preschools starting young. Policies to really support the approach to having healthy corner stores and having sort of mitigate those food deserts that we have, and improve identification of unmet needs and referral to resources. And something that was brought up there was to sort of make sure the systems talk to each other too. If we screen and find it that you screen in one place, that you really have that information can be shared to other access points for the families. Okay, next topic is substance use prevention. In our statute says that grades K to 12 shall receive instruction on the effects of alcohol, tobacco, prescription drugs, and controlled substances In addition to that, good to point out that we have a tax on vaping products that will go into effect in 2022. When it comes to outcomes in this big area, I would say it varies in Indiana. We are about average when it comes to the prevalence of past months use of illicit drugs use among Indiana youth. We're 8.5% versus the national average of 8.2. However, our vaping rates are much higher than the national average, and 17.1%. And Dr. Box mentioned this too, because this is something captured in that survey we talked about as well. So that's high. Indiana also ranks 39 in the nation when it comes to its tobacco tax rate. So things for the commissions to consider are there ways to strengthen the curriculum that could be more evidence-based than just the instruction that is currently listed? And are there ways to account for the evidence that tobacco consumption is really inversely related to tobacco tax rate?
Mhm.
Next.
There was some agreement with that last comment.
We're going to talk about sexually transmitted infections, surveillance, and prevalence. We need to talk about that because we're talking about child and adolescent health, and it's an important part of adolescent health. Our statutory requirements require that an abstinence curriculum is taught. As you can see, those are out. All our statutory requirements are listed on the left-hand side there. It doesn't mean that there cannot be a comprehensive curriculum, but it varies whether that's in place or not across the state. With the curriculum we currently have, the outcomes we have right now is that almost 32% of Indiana high school students report that they are sexually active, and that's defined as having had sex in the past 3 months. And 15.5% of those report that they did not use any measures to prevent pregnancy. And things for the commission to consider in this area. Are there things we can do to promote that HIV and STI screening is actually happening in our detention center where some of our youth are? Something that was pointed out to us by our stakeholders was really the variation across our states. And there was an ask whether there was an opportunity to develop a best practice protocol as a statewide resource that local health departments could access. And then promote STI screening as part of routine screening for adolescents, making sure that for those in foster care, where that is, when that screening is needed, that people are aware of that sometimes needs to happen. Really increase the provider on that topic, increase the provider education on adolescents, STI prevention and testing, because this goes both ways. There's also the providers being aware, knowledgeable, and comfortable of asking some of those questions.
Yeah.
And really increase the awareness of the access to prenatal and postpartum care that we do have in law for our youth that are pregnant. We're also going to talk a little bit about injury and violence prevention, huge topic. There's a minimum of 1 semester course on safety education that must be taught, and it's in 8th grade. Of course, we have various federal, state, and local laws addressing injury prevention through all different legislation. Our outcomes are pretty stunning. The leading cause of child and young adults death in Indiana are accidents. And suicide is the second leading cause of death for Indiana youth that are aged 10 to 14.
Unbelievable.
We know that most of our high school students that are riding bikes are not using bike helmets. Something that was pointed out, it's sort of related to this topic and pointed out as a true Indiana strength, was our stakeholders really talked about our juvenile justice reform.
Mm-hmm.
And its participation in the juvenile detention alternative initiatives. So things for the commission to consider would be to add evidence-based curriculum on healthy relationship, assertive communication, and injury prevention. Think about partnerships, such as Ohio have a Store in Safe partnership, which is a partnership of providers, safety experts, and the community, regardless where people stand on the question of gun rights, to come together and to keep youth safe from unintentional firearms death and suicide, and treat this similar to we do other safety issues. For example, that program has one initiative they have done is to provide gun locks for families who need them, for example. Other things to consider would be to provide helmets, just like we provide car seats to low-income children who need them and have bikes. So, and we do know that if you legislate regarding bike helmet, that the bike helmet use certainly goes up. So we've talked about a lot of things. There are a few additional things that sort of came out that maybe we couldn't quite get under one of the umbrellas of the other topics. So one thing that was pointed out, that the health coverage is so important. Is there, how do we improve the health coverage transition from children aging out of Medicaid or aging out of their parents' insurance? Do we have enough awareness? I mean, this is something Dr. Box and her team are working so hard on with the Healthy Babies program for infant and maternal mortality, but sort of increase that awareness, making sure that pregnant mothers really are connected to prenatal care. What are our strategies to increase behavioral health screenings so that we know before the outcome is bad? What are our strategies to address behavioral health workforce shortages, not just in schools that we talked about, but also outside of schools?
Yeah.
And what can we do to make sure when we screen for social determinants of health that information is shared between entities, so that families are not asked and asked and asked again, but that when they're asked and we have identified a need, that our different systems know about that need, and sort of and follow up according to what the screening has resulted in. I think that's my last slide. I'm very happy to take questions. There are additional pages in the appendix with some of the details. Happy to take any questions. Thank you.
Thank you very much, Dr.
Excellent.
On page 17, refers to claims reimbursement. It says IEP service. That's individual education plan. So to clarify for the members of the commission, those are reimbursements for children who are required to have an IEP. Is that not correct?
That is correct, and that is how it has been. The new legislation that's coming through and it's clarified this legislative session will make it possible for some Medicaid services to also be reimbursed outside of the IEP. But the IEP is that individualized education plan that a child either have or does not have, but there will be some services that can be reimbursed outside of that for children on Medicaid.
I'm just trying to point out to the commission, that's sort of a limited group.
Yes.
And then do you have any, do you all at FSSA have any thoughts about seeking other Medicaid reimbursement for other types of provision of services within school buildings? Have you dealt with that specifically?
I probably have to take that question back and sort of have some more details. I do know that the new legislation will allow for something that are not in the IEP, but
we're finding that because of the local health departments, sometimes they're limited budgets. They don't have much opportunity or time to apply for Medicaid reimbursements.
Right.
And so this touches on that question, which is a pretty big question, where we might be able to find resources other than just appropriating our own funds. And I would be curious if you might be able to analyze that within the schools to any extent or through your offices, whatever you might be able to find out.
I will definitely
Okay.
take
Thank
that back and come back with information.
Kim,
Just to tag on quickly, I was thinking the same thing as we went along, that I know local health departments really struggle with even trying to get Medicaid reimbursement because of the challenges that I guess there's a similarity. My question is the pharmacy, I forget the acronym for the program, but the vaccination that private pharmacies don't typically provide. is that
VFC,
related to-
VFC.
Is that also related to like an administrative burden of processing or a different reason that they don't provide
It's,
for doing it?
it oftentimes, from the local health department standpoint, is all the documentation that they have to do. Temperature regulation, you know, the documentation that they have to give back is why many people give up giving the VFC vaccines. Mindy, do you want to elaborate?
I think also the expiration of vaccines is a concern for those that do it privately. They have to undergo inspections and certain things, alarming, like actual alarms and a number of those things. So it's sort of a burden to do, and so many have opted out of that privately, and that's primarily done through local health departments.
And it does require sort of that those vaccines are stored separately. So there's also just the administrative burden of having two systems.
And in addition to that, our pharmacies that do vaccines for children don't in general do them. They do vaccines in kids, don't in general do vaccines for children. I think Meyer is the first pharmacy group that we got to kind of get on board with that. So we are working really hard to try to engage more. I'm like, pharmacies, if you want this business, then you need to do our VFC vaccines too. So it's accessible for our kids.
So a number of physicians have gotten out of getting vaccines because of the cost and things getting outdated. And it's been the acquisition costs have been not consistent and difficult. A couple questions and a couple comments. First question, when dealing with schools and the different school nursing or the other acronym you use, is schools construction cost higher for the square footage of those? Like if I build a business, it's not medical, it's so much cost per square foot because of rules and regulations. If I do a medical facility, the cost per square foot goes up because of additional requirements. Is that a barrier for the schools?
I don't know the answer to
Okay.
that. Are you asking specifically about the school-based health clinic?
Yes.
We'll have to take that back.
Okay. And then you were talking about injury prevention. So some good resources, if you haven't already looked into, is there's some good resources in the American College of Surgeons Committee on Trauma at the AMA. And I always try to encourage folks for good guns safety education, such as through Department of Natural Resources. There's some private institutions in the NRA, but anybody that's going to do good firearm safety education, I think is key. I'm in Southeast Indiana, so there's a lot of gun safety education going on. That's a traditional family event. And not to out anybody's what say that folks are doing, but it's a rite of passage in many families to teach younger folks how to hunt, but how to do it safely. But just some additional thoughts.
Thank you.
I noticed there wasn't anything with respect to funding about CHIP. And how does CHIP, the Children's Health Insurance Program, play into the funding of all of these things?
So there would be children on Medicaid that are covered under the CHIP program. So they should be able to access those Medicaid services that through schools. For example, that would be one of the programs children are covered under.
But does a school have to, do the schools know which of their kids receive CHIP versus who are on Medicaid versus private?
I think it's a great question. I think it really points out that it would require the school to think and act more like a healthcare provider, which comes with some challenges to know all that, right? So.
And then I know that I was just trying to look it up, the whole FMAP issue, which I had not remembered, that whole challenge about different FMAP rates for our state. I don't recall how ours is compared to other states. It's the matching.
Federal
Does someone want to remind me where Indiana is in that and how that could impact? I know enough to be dangerous. I don't recall this, but I knew there was something about this. And I knew
Shane,
CHIP has always been something that at the federal level, you know, we always try to fund CHIP or increase funding to CHIP because everybody cares about children's health care. But now I don't recall what our state's FMAP is, and is there something we could be doing to improve reimbursement or the match? Anyone?
Shane, do you have some
Pardon?
input?
Sure. So in aggregate, Indiana gets about 66% of Medicaid expenses reimbursed by the federal government. So that match would be obviously provided by the state. CHIP has historically had that enhanced federal match rate. However, more recently, the federal government has started to stair step that down. I don't recall the exact percentage that that's at, but it has required some shifting around of different resources at the state level to make sure that we still continue to fund that program as it should be, so it's kept whole, but it has required significantly more state or dedicated funding than it has previously. So I believe it's still richer than the 66% we would normally get, but it's not quite as enhanced as it had been previously.
Right.
Well, I think it's a great question, and I do think, it's great job, something else here, I think Medicaid coverage should be a part of the discussion. When we look at our rates of enrolling children in CHIP for eligibility, they're not great. We have a bigger gap in some other states. And so maybe part of that work can start with working through schools. The coverage is going to be a big deal. We have a lot of folks who are eligible for Medicaid now from the pandemic. We're obviously blessed to have the Healthy Indiana plan, which has been lifesaver, just such an incredible safety net through this pandemic. But soon we're going to be disenrolling a substantial number of teachers that everybody's kind of waiting to see what happens with the federal public health emergency when that ends. There is some talk about giving states maybe a bit of an enhanced boost in their FMAP that was tied into some legislation in Congress that's not moving now. I think there is a bit of a chip cliff still out there, is that right? So I think that maybe fits in the next budget. So tying all this in together, I do think it's important. We have, it's hard to even have a baseline right now because we have expanded eligibility through the pandemic. But if you go back even before the pandemic, we have a Healthy Indiana plan. We have a marketplace, we have options, but our rate of uninsured is about twice what it is in Michigan. So I do think as part of this, when we think about public health, coverage isn't everything, but it's a big part of it. And I do think this will be an important part for us to look at when we get to it.
You know, speaking from a budget standpoint, Brian, you've been through this as much as I have. It sounds like, you know, we always have the budget presentation, then we have the Medicaid budget presentation. And it sounds like one of the things the commission might be able to do at a minimum is to bring to the attention of state government that when they make these budget presentations, that the Department of Health and the schools, and other people have input that needs to be taken into account by FSSA when they make the Medicaid presentation. I'm not sure that I think that's ever been done.
Well, I don't know. I think the Medicaid presentation has always been just for real fiscal geeks and those that follow us really closely. But I think you raise a good point that the implications are. I know there's been a lot of interest in recently from I know there's been a lot of great work to try to increase the ability for schools to do given some options to be able to bill for telehealth and other things. So I think increasingly it's being recognized that it can be an important tool. But yeah, that the linkage between Medicaid and education, and now if we think about extending it to public health, it kind of gets back to what's the ROI? What are we leaving on the table
Right.
here? It was interesting to see that chart, and there's some growth in things like administrative claiming, some growth in reimbursement, but I think it was only 100 or so of the LDAs that were doing it. And what's the universe?
413, I believe. So, yeah.
So we know there, right there, and I think, I just, as we look at you where we're talking here, it looks like DOE has some great resources on their page. So I think DOE bringing them in, looks like they really have some great tools. It looks like there's even a vendor that helps school corporations with that. So we can leverage maybe the private sector to help work with schools to save them money that they otherwise will have to take from their general budget. So yeah, I think this education piece and Medicaid and the impact on public health will be an important area for us to look at.
Yeah, Shane and Kathy, I think there may be some reason why we need to try to look into that to see if there's at least a recommendation that we can make, even if it's not a tangible action that would be taken by the Department of Health in this overall plan.
The overall picture has to, I think, in my mind, include some way to get our public health people charging Medicaid for what we can charge Medicaid for.
Right.
Because we leave so much money on the table, and it's something that we consistently bang our head in the, but it also occurs with our funded community health worker programs. They can't afford to charge Medicaid for what they're doing. It occurs with our public health. It occurs in our school systems. So it seems like to me there needs to be a way to carve that out or plan that to make that easier to charge that. I'm sorry, Hannah, you trying to ask?
And then we need to make sure we have the workforce to deliver the service. And I just wanted to kind of provide some additional context to the figures that Dr. Fennell provided today. So she was referencing a report that our team put together for the state of Indiana on the state of the school health workforce. And yes, it is the case that 2% of our licensed health professionals that were included in the report reported either that they practiced in a school health setting or a school-based specialty, and I would encourage you to check that out. But what I want to call attention to is that we have 1,860 public schools in Indiana, okay, and 413 agencies or local area school districts, right? So of the 1,700 nurses, that registered nurses that reported school health in their specialty or setting, that is only accounted for in 1,300 FTE, because we're actually able to break it down into the number of hours they report in a school. And when you look at how many that is among our local education agencies, that's only 3 RNs per school district for all of the children in the school district. When you look at behavioral health, okay, among our, let's see, 507 clinical counselors, so that includes mental health counselors, marriage family therapists, that whole group of counselors that we have in the state of Indiana. We have 507 that report that they work in school health or have a specialty in school health. Only 600 or only 368 FTE, which is less than 1 behavioral health counselor for every single school district that we have in the state of Indiana. So if we are worried about the behavioral health of our children and they are at school for a significant portion of their growing years, we absolutely have to address workforce. Now, whether that's the workforce right in the school or whether it's through partnerships, right, with the local health agencies, behavioral health organizations, that can be decided and determined. But I just want to make it clear that we need to figure out funding. But we can give people the golden ticket of insurance all day long. If there are not providers to see them, to provide services to them, it doesn't matter.
Well, and I actually was wondering about that. I mean, given this last couple of years and all the stress on the workforce, both on the clinical side, education, have you all in the state actually, has there been a decrease in the number of clinics able to provide vaccines for children? I mean, that's because of the burden as you're talking about. I mean, what's happened with the nursing workforce and
I ask my immunization director all the time and he assures me that doesn't happen. And yet I hear more and more about people that are giving this up. Mindy, do you have a feel amongst that?
Health departments don't generally stop doing that. That's kind of.
No,
like
you
one
can't.
thing. But historically, in the private sector, there were quite a few that did it. They got out of that business.
Yep.
And it was all local health departments for the most part. I don't know the exact number, but I would guess it's high in the 90s.
Yeah, I think very few providers' office, even pediatricians' offices oftentimes
that's
do
what
them
I wondered. And I
anymore.
wondered if someone given it up, given the stressors, even if they were doing
That's
it.
what they cite, that's what they
Mhm.
tell us. I mean, over the years, and I'm talking 10, 20 years of hearing about it, less. It was because of the burdens associated with providing that and having it separate from what it is that we have to do that. We have local workers and then we have VFC.
Yep.
Yeah.
You got all these different inventories and.
They got to be separate.
It is difficult.
Just sort of my previous life, we had VFC start clinics, and that's exactly what we did. The administrative burden of just posting the VFC was so cumbersome that it was beneficial. And we knew the health department.
Yep, that's why you got out.
So we got out and we're patients, but we never had a conversation. Say, we're getting out of this. And you fix it.
And just know that all those regulations that surround VFC come from the CDC. We literally, I know you are, but I thought you might know somebody over there.
But I might know somebody.
But it does highlight the important sort of access disparity, right? Hours and so forth, whether you can get it from your local health department or
And then
somewhere
over
else.
this last 2 years, I mean.
Yeah.
it Just made it worse, because if we were the only provider for the, like in our county, that's like 50% or something like that, that needed it. Where were they getting it? It was difficult, all postponed.
The ordering rates are tremendously down, like 100% plus, and have not gone back up. And it's really because those local health departments that kept their doors open were doing COVID and still doing COVID, I understand. And some just closed their doors.
Yeah.
So if that's your only source of VFC, those children have gone without.
Yes, Brian.
That's particularly interesting is that I didn't realize it was administrative code, didn't know what the mechanism is that just requires for direct school corporations to provide health services. So they do, but it sounds like we identified here something that's similar to what we identified when we looked at the county government. Is that the gap between what's on the books and really realistic. There's some things that, yes, the administrative code says that if you have it now, it's sort of unenforceable because it's not reasonable. And so I think that's one of the things after we have kind of our other recommendations, it will be important to go back and make sure when this process is done, and I think we will be successful, we've kind of trued up what those expectations are. Because we shouldn't be requiring the statute or code things that we as the commission know can't be done. So I think that's where our job is to figure out how to get resources to make sure they get done.
Yep.
Or go back and if there are a couple of things that say on local government that we don't think should be made right across the board, we'll have to fix that. But I realized that there were some requirements in the administrative code.
Yeah.
So when we talked earlier about making sure we got that discussion with county governments and making sure that they're on board with that, sounds like a piece of this will be having that with superintendents.
Yeah.
I just think.
Yeah, we're getting to the headache stage of this thing. I'm not sure. We have a pretty good sized charge in terms of trying to deal with the public health system. I'm not sure we could reform the education system as just a part of that exercise. So,
I'm just saying that they ought to be realistic of what's expected of them. We recognize that.
good point.
They certainly they can deliver. And I think we've identified some ways that maybe we can help them through the training and other things.
Obviously, a very important part of this discussion. Yes, Dr. Halverson.
Thank you, Mr. Chairman. I want to compliment you on this paper.
But just also to point out on the fact that, remember the three functions of public health, one of which is assurance, and the provision of medical care services is the responsibility of public health to assure that those services are available, not necessarily to provide it. And that's why I really appreciated the recommendations that you made relative to prevention. And I saw those in there very strongly. And in particular, again, want to acknowledge and thank you for pointing out the issue around injury and violence prevention, which is the #1 cause of death for people between 1 and 44. And I think that there's a lot that we could and should be doing, especially for the pediatric population. But if you look at it, it is an important part of public health. And I would dare say it's probably one of the most neglected areas of public health. And I don't think that here in Indiana, we're any exception to that. So I think that there are a number of recommendations that you made, and just generally looking at our injury prevention and control, trauma and EMS in particular for our state. It's a huge part of the responsibility of public health to do that. I know there are some efforts underway, but I do think that this is often a neglected area, and I hope that we can remember that as we forecast our report. And thank you so much for your good. And I thank you for mentioning in particular some of the issues that frequently get lost. For example, issues around nutrition, the STDs, the tobacco issues, vaping products, all of those things are so important, and they go into the prevention areas. Thank you.
More to come on the EMS
Looking
trauma
forward.
stuff. Next meeting.
Thank you. Yes. Any more? Well, thank you very much for your presentation. I would remind everybody we meet again Thursday, March 17th, 1 p.m. Thank you for being here. Anything else, Dr. Fox?
Nope, just be careful in the rain or sleet or ice or whatever we get in the next day and a half. Thanks for coming, everyone.